We'd like to next approach clinical issues. And the first one, I'm going to ask you, Jessica. This is Jessica Lonnie from Georgetown, and she runs the Georgetown Headache Clinic. And it's my pleasure. I've had the opportunity of working with her for a long time. It's a pleasure to have her here. So I'm going to ask you, Jessica, what are some of the challenges in diagnosing migraine?
I think that's a great question. There's many challenges that are unique to diagnosing migraine. I think the first is getting the patient to come into the clinic and be seen by a provider who wants to hear the symptoms they're having. I mean, how often are we in clinic and we ask a patient about their symptoms and they say we're the first one who's asked them these questions, or we're the only ones who are looking at their calendars or listening. So I think one of the barriers is having providers who listen to the patient, who care, and then who really get the patient to move forward in telling us what brings them there, how often they're having headaches, and how are they feeling, what are their symptoms.
David.
I think the other issue too is that headache is so ubiquitous. It's a clinical diagnosis. There are no objective biomarkers. You know, we can't image it, we can't take a blood test, and so it's a challenge. And when you add to the fact that in medical school I got zero education in this area, and even in residency, and I'm not that old, it hasn't been that long ago, I got 2 hours. And so, you know, in my senior year of neurology residency, I still really knew nothing about migraine, and every time I saw someone on my calendar who was coming in with a chief complaint of headache, I would shudder because I didn't have a systematic approach to the diagnosis and to the management. And clinicians and doctors don't like feeling incompetent, right? And so that's a problem.
I think also we spent a lot of time, maybe too much time, emphasising all the differential possibilities in perhaps when teaching students and so forth. The landmark study, and Stuart could comment better than me, or the lead author. I mean, it shows you, if I remember correctly, that you put migraine and migrainous headache together, and more than 90% of what turns up to see primary care physicians complaining of headache is migraine. And maybe it's at some level we've made it difficult for people because we give them a list of 50 different things to remember, when actually what's number one at the top is migraine, and what's number one at the top is migraine, 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 migraine. So it seems to me like, I think at some level we've done that kind of neurological clever thing where we know that someone could have nummular headache, so we obsess about that a little bit, whereas, you know, we do a lot of good in the world if we just followed the landmark study and thought a lot about migraine.
And just to add a little bit about it, what was interesting in that study is we used the International Classification of Headache Disorders, and we evaluated attacks in patients who came in with a chief complaint or a secondary complaint to either general neurology or primary care with a complaint of headache. And as you said, 94% of the time it was migraine. But what was a challenge, getting back to Steve's original question of what's a challenge, is that if the patient said, I think I've got sinus headache, then the doctor diagnosed sinus headache. If the patient said, I have tension headache, then the doctor diagnosed tension headache, regardless of what the actual diagnosis was, when it turned out to be generally migraine. And we can leave this, and very similar to what you said, with what my old mentor used to say, Charlie Barlow, who wrote a textbook on pediatric headache at Boston Children's, and his adage was, it's always migraine. And at the time, I didn't realize that he was very wise.
Well, and I think you're right, Peter. We've done the community, neurological community, disservice by overly complicating this. When you think about primary headache disorders and the classification, it's either tension-type headache, which neurologists almost never see in clinical practice, so almost take that off the table, or it's a TAC, a trigeminal autonomic cephalalgia, or it's migraine in the primary headache sphere. So if you got a patient with a side-locked headache and it never moves, right, from one side, ask about cranial parasympathetic features, and maybe you've got a TAC. Otherwise, invariably, it's migraine. The problem is, and I think what makes neurologists nervous, is that the criteria, the diagnostic criteria for migraine, very sensitive but not very specific, so that you could have carbon monoxide poisoning, meningitis, subarachnoid hemorrhage, arterial dissection, venous sinus thrombosis, and the list goes on, that will present with a phenotype of migraine. And so that's, I think, what makes neurologists nervous. You can be nauseated, you can have sensitivity to light, and you can have a pounding headache. That doesn't necessarily mean it's migraine.
David, what you said is brilliant. I think the classification has to change, where we could have the phenotype of migraine as a phenotype, and then when does it become a disorder? So what is the difference between a migraine attack and a migraine headache? Exactly. And think about it. It requires 4 attacks. Why? We should be diagnosing phenotypes and more often the clinical disorder that leads to the phenotype. We're not doing that.
No, you're absolutely right, Steve. And one of the other problems, of course, is that 12 to 15% of the population has migraine. So the likelihood that someone's going to come in with a secondary headache that recapitulates the migraine phenotype, right? If you've already had migraine, and I come into the emergency room now with a severe headache, and it resembles my prior migraine, but this time it's a dissection, you can see how that could be overlooked.
But usually there's a change in pattern, as you yourself have talked
You're
about.
Dr. Snoop. Tell us, Dr. Snoop.
Yeah, tell us a little bit about that.
No, it's all about the change in not necessarily the phenotype, but the change in the pattern, right? And you worry about that. You worry about a patient who comes into the emergency department because they're coming in for a really good reason. They would rather not be there. And the idea that they're seeking drugs and seeking medication, the overwhelming majority of them are simply not. They're either in status, migrainosis, and looking for pain relief, or they've got another problem. And so you really have to ask about onset, and you have to ask about the pattern. Has there been an increasing frequency? Has the pattern changed? So there are a list of very simple questions that can be very effective in eliminating secondary headaches. But I think that's what makes neurologists nervous.
I think you bring up a good point about the emergency room, but often in clinic we'll see patients who mention this change in pattern, and it'll be subtle sometimes. It'll be that all of a sudden I'm using more acute medications. Now my acute medicine isn't working as well. While that can still be underlying migraine, I think it's important that we recognize that these might be the patients we need to stop and ask a few more questions and see if anything else has changed. And that'll help keep us in a safe zone of not missing that this person has migraine but now has developed a different type of headache that might have the phenotype of migraine, but yet there's been a change significant enough we might need to image them at this point, do a more extensive exam that visit, and pick up if there's any other issues.
At the time that sumatriptan was launched, we were saying that it was specific for migraine. And a friend of mine, and we actually published this paper, had a patient that came in with a phenotypic migraine headache. He gave the patient sumatriptan, the headache went away. Turned out later she had another subarachnoid hemorrhage. We published a paper, the headache of subarachnoid hemorrhage responds to sumatriptan. And that was based on the concept that the drug was not only good treatment, but diagnostic. And I think one of the things we learned over the years is because something responds to drug X doesn't mean that, which is the indication, means that it diagnoses it. That's important.
It's worthwhile saying that history taking is called history taking because you have to take it. So, if you give someone a series of questionnaires like fill in the form, and are you bothered by light, and they say no, if you have to engage in history taking, does light bother you? Not really. What do you mean by not really? Do you mean a little bit, or do you not? If you don't take the history, you will have trouble diagnosing the problem. But if you engage with the history, pick on the first visit, it will save you a lot of time going forward because you get the diagnosis right and you get the person's confidence. History taking is a therapeutic bonding exercise in medicine, which also has incredible value from a diagnostic perspective. And I think that a problem with diagnosing migraine almost is you actually have to take the history. And there's no easy way to get around that. But gee, it's rewarding when you do.
And I would just like to add another adage that I think is useful in terms of, for example, your patient with the subarachnoid hemorrhage. And this was an admonition by Fred Sheftel, who also taught me an awful lot. And he said that when a patient comes in to a neurologist and the chief complaint is about a headache, one should be nervous. And if the patient comes in and complains about headaches, one can relax a little bit because the presence of the headaches suggests a pattern of recurrence, of recurrent and generally stable pattern. Whereas a new headache where the patient is actually complaining about the new headache should be a cause to take a more careful history, as Jessica said. And I think that's a very useful
good
added.
point. And you were saying that people get misdiagnosed because they say they have a tension headache or sinus headache. When I hear that, my reaction is, what do you mean by that? And then you get to the truth.